Imagine your lungs, which are supposed to be filled with air, suddenly begin to fill with fluid. Not from the outside, like in drowning, but from the inside. This is the reality of one of the most severe conditions we face in the intensive care unit, acute respiratory distress syndrome, or ARDS. Today, we're going to explain what ARDS is, what causes it, and how we fight it. So, what exactly is ARDS? It's not a specific disease like pneumonia. Instead, it's a syndrome, a catastrophic pattern of lung injury. The core problem is this: the tiny, delicate barrier between the air sacs and the blood vessels in the lungs gets damaged and becomes incredibly leaky. This allows fluid to pour out of the blood and flood the air sacs. This internal drowning prevents oxygen from getting into the body, leading to a life-threatening lack of oxygen known as severe hypoxemia. ARDS doesn't happen on its own. It's always triggered by a major insult or injury to the body. We can think of these triggers in two main categories. First, there are direct injuries to the lungs, with the most common cause being a severe pneumonia. Other direct causes include aspirating stomach contents or inhaling toxic smoke. Second, and just as common, are indirect injuries. This is where the problem starts somewhere else in the body, but the lungs suffer the consequences. The most common indirect cause is sepsis, which is a widespread infection in the bloodstream. Severe trauma, burns, and pancreatitis are other common indirect triggers. Let's look at what's happening on a microscopic level. It all starts with that initial insult, which triggers a massive, uncontrolled inflammatory response throughout the body. This inflammation destroys the barrier between the lungs' capillaries and its air sacs. Fluid, full of inflammatory proteins, floods into the alveoli. This fluid washes away a critical substance called surfactant, which is like a lubricant that keeps the air sacs from sticking shut. Without surfactant, the alveoli collapse like wet balloons. The lungs become heavy, waterlogged, and incredibly stiff, making every single breath a monumental effort. Because ARDS is a syndrome, we need a strict set of criteria to diagnose it, known as the Berlin definition. First, the symptoms must have started within 1 week of a known insult. Second, a chest X-ray must show fluid in the lungs on both sides, what we often call a whiteout. Third, we have to be sure this fluid isn't being caused by heart failure. And finally, and most importantly, we measure the level of hypoxemia using something called the PF ratio. This tells us how severe the ARDS is, classifying it as mild, moderate, or severe. A lower PF ratio means the lungs are having a harder time getting oxygen into the blood. The cornerstone of treating ARDS is supportive care with a mechanical ventilator, but we have to use it in a very specific way. The strategy is called lung protective ventilation, and the main idea is less is more. The lungs are already injured and fragile, so our goal is to prevent the ventilator from causing even more damage. To do this, we use very small breaths, known as low tidal volumes, to avoid overstretching the few healthy parts of the lung that are still working. We also use a setting called PEEP, which provides constant pressure to help pop open the collapsed, fluid-filled air sacs. This approach is so important that we will often allow the patient's CO2 level to rise higher than normal just to protect the lungs from damaging breaths. For the most severe cases, lung protective ventilation might not be enough. That's when we turn to advanced therapies. The most common is prone positioning, placing the patient on their stomach for at least 16 hours a day. This simple act uses gravity to help recruit and open up parts of the lungs that were collapsed, and it can dramatically improve oxygen levels. We may also use paralytic medications to ensure the patient is perfectly in sync with the ventilator. And for the absolute sickest patients, we have ECMO, which is a heart-lung bypass machine that oxygenates the blood outside the body, allowing the lungs to rest and heal completely. Surviving ARDS is a major victory, but it's often just the beginning of a long and difficult recovery. It's a devastating condition with a mortality rate that can be as high as 50%. Many survivors will face long-term challenges known as post-intensive care syndrome, or PICS. This can include profound physical weakness, cognitive issues like memory loss or brain fog, and significant psychological trauma, including PTSD, anxiety, and depression. Recovery takes time, patience, and a tremendous amount of support. ARDS is a formidable challenge in critical care, requiring a deep understanding of lung physiology and a commitment to gentle, protective support. Thank you so much for watching. We know this is a heavy topic. If you have any questions about ARDS, or if you have a request for another critical care topic you'd like us to cover, please let us know in the comments below. If this video helped you understand this complex syndrome, please give it a like and subscribe for more educational content. Thank you for being here.